A very good evening. On behalf of Ajanta Pharma, I, Dr. Deepak Bachani, from the Medical Affairs team, would like to welcome everyone present today for this very interesting, what I may call a scientific fest webinar, the international speaker webinar on the topic of Vonoprazan, the game changer in the management of acid-peptic disease. Now, as we know, Vonoprazan is the newest introduction, the newest kid on the block, which definitely has huge potential. Through the scientific webinar, we will look at experts from the international arena, as well as the who's who from the national arena, who have thought leader status, prolific international thought leaders, to discuss on this molecule. To take it forward, before we get into the scientific discussion, I would like to make a short corporate presentation about Ajanta Pharma. Now, Ajanta Pharma is a 50-year-old company which has been serving healthcare needs globally. We believe in trust and innovation. It's an Indian multinational pharmaceutical company which serves global healthcare needs through empathy, innovation, and technology. These are our three pillars in terms of overall the thought process and the philosophy. As I mentioned, it's an Indian multinational pharmaceutical company having presence in 30 plus countries with 500 plus products. We have 7,000 plus Ajantites from 30 plus nationalities as part of Ajanta family. Now, within the pharmaceutical space, Ajanta can proudly state that we have an advanced R&D center, a unique one, which is a 1 lakh square feet area with 750 plus scientists working in this advanced R&D center. Now, this distinguished and distinct R&D center, in fact, ensures the complete value chain in terms of pharmaceuticals, from formulation development up to synthetic development, involving the very important stages of analytics as well as regulatory affairs. Now, we have 7 state-of-the-art manufacturing facilities in India, 2 of which are US FDA approved, and the remaining ones have international approvals from the various regulatory agencies. Now, on the slide, you can see 2 of them, which are very prominent. They have the US FDA approval, as I stated, in Paitan and Dahej in India. And these are the remaining ones, which, as stated, have approval from the various international regulatory agencies. Now, because of extensive work within the healthcare space, within our core areas, and with help from working with healthcare workers like all of you present today, HCPs, we have got extensive awards and recognitions as shown on the slide. Prominent among these being on the top, the Time Magazine Young Maker of the Year Award. Now, this award was received from the very Honorable PM of India, Mr. Narendra Modi. Also, the recent awards and recognitions include, which are shown on the slide. Distinctive amongst these are the Hurun Award, which was the most respected entrepreneurs award in 2023. And this year, we got the Golden Peacock Business Excellence Award of 2024. Now, as we set foot into gastroenterology with this newest molecule, we would always strive to be your scientific partner. This is the philosophy with which we work, and this is one such step in that direction. Now, this was about the corporate presentation. Now, as mentioned earlier, for today's meeting, we have prominent international expert as well as the who's who in terms of national experts whom we're going to have. Now, before we set foot into the scientific discussion, I would like to make a short presentation about their introduction. Now, as protocol says, I said that these doctors are the who's who, but as protocol states, we have to do a short introduction. Now, an absolute pleasure to have with us as moderator for today's meeting is Professor Dr. V.G. Mohan Prasad, sir, the founder and chairman of VGM Gastro Center at Coimbatore, the inventor of Hemosil spray. Sir is the professor at Dr. MGR Medical University, Tamil Nadu, the national past president of the Indian Society of Gastroenterology and the Society of Gastrointestinal Endoscopy of India. Sir he writes extensively. He's been the chief editor of the book on acid-peptic disorder and beyond, has been an advisory board member on various examinations, advisory member for the National Board of Examination, as well as the professor for DNB medicine. Distinctively holds the Guinness Book of World Record for hepatitis awareness. An absolute pleasure to have you with us, Professor V.G. Mohan Prasad, sir. Now, also on the panel, as I stated, all the panelists consist of an August panel. We have Professor Dr. Shobhana Bhatia. Madam is the professor and HOD of gastroenterology at the National Institute of Medical Sciences, Jaipur. Prior affiliation as Director of Neuromotility at the Department of Gastroenterology at the Sir H.N. Reliance Hospital. Madam has been the former faculty of the very distinctive SATE GS Medical College and KM Hospital, is the international committee member of various societies, including Asian Barrett's Consortium for Barrett's esophagus, Asian Pacific Consensus Meetings on GERD 2016, and absolute pleasure to have you with us. Warm welcome to you, madam. Now we also have Professor Dr. Sunil Kumar Dadich. Now, sir is Senior Professor and HOD of Gastroenterology at SN Medical College, Jodhpur, has been training fellows for DM since 2011. More than 50 scientific research publications in both national and international journals, 15 book chapters, the governing council member of INAZL from 2018 to 20, 2021 to 23, and recently at RAGA ISG from 2020 to 2024, the chairman of scientific committee of ISG Con in 2022. Welcome to you, Dr. Dadich. Next on is Dr. Sanjay Banerjee. The sir is a senior consultant and the head of Department of Gastroenterology, ILS Hospital, Dum Dum, Kolkata, the faculty for DNP Gastroenterology, the former faculty at NRS Medical College and Institute of Postgraduate Medical Education and Research, Kolkata. Sir has been a member of editorial committee of various journals, has extensive publication experience like all the other August panel amongst us. Warm welcome, Dr. Banerjee. Next on is Dr. Ravindra B.S. Now, Dr. Ravindra B.S. is the Director of Department of Gastroenterology and Hepatology at the Fortis Hospital and Meenakshi Institute of Gastroenterology, Bangalore, with previous associations consisting of Gleneagles Global Hospital, Bangalore, the Meenakshi Mission Hospital, Madurai. Sir has been awarded by the former PM of India, Dr. Manmohan Singh, and the Chinese Premier Wen Jiabao in Chinese Parliament in Indo-China Joint Medical Mission, and author of the textbook on portal hypertension. Sir, a warm welcome to you, Dr. Ravindra B.S. Now I hand over the session to Dr. VGM, sir, Dr. VG Mohan Prasad, sir, to take forward the scientific discussion and to introduce our international speaker.
Thank you, Dr. Deepak Bachani, and very grateful to Ajanta Pharma for inviting me to be a part of this wonderful symposium. I really deem it a great honor and privilege to be a moderator for the session where Professor Dr. Ronnie Fast himself is here to speak to us about Vonoprazan. So people who have gone through literature would affirm that there are multiple publications in the past 3 years from his unit on Vonoprazan. And what is more interesting is, like, he's not only professor of medicine, Case Western Reserve University, and a medical director, Digestive Health Center, and a director, Division of Gastroenterology, Hepatology, and a head of Esophageal and Swallowing Center, Metro Health Medical Center, Cleveland, Ohio, USA. He is also the editor-in-chief of the most prestigious journal of neurogastroenterology and motility, and also the editor-in-chief of Journal of Clinical Gastroenterology, which is very popular even in India and all over the world. He's a world expert in the understanding and treatment of GERD. And his awards are numerous, including the Rome Foundation and Aldo Torsoli Foundation 2023. And also, he's been awarded for his outstanding academic record in research, education, and patient care in disorders of gut-brain interactions. And what is more, appropriate to mention here is a wonderful human being. And yesterday we had a brief opportunity to interact with him, and he is so sweet, so humble, so nice, in spite of being such an elite academician of the globe. So we are very, very proud to have Professor Ronnie Fast with us to deliver this prestigious talk on Vonoprazan. And also my hearty congratulations to Ajanta Pharma for entering into gastroenterology arena with a big bang. So you come with one of the best molecules today on acid suppression. I'm sure we will find more and more interesting facts from Professor Fa's lecture. And as Vonoprazan comes in, we'll have to welcome this new kid in the block because we started with cimetidine, ranitidine, and oxmetidine, tiotidine, famotidine era, and then we moved on to PPIs, and now we have come to potassium competitive acid blockers, the PCABs, and the first of its kind, the Vonoprazan, to enter into India. It has been there in Japan for 8 years and probably 9 years as of now, and also in China and in United States at least for a couple of years approved by FDA. And thanks to DCGI, now we have this molecule here. So the globe has got more experience, and Professor Fass has got so much of research in that field. So we're all ears. So without much ado, let me request Professor Ronnie Fass to start his talk. And after his talk is over, we'll have a panel discussion. So please be with us. We have national experts here to add on and highlight some of the features. So thank you so much once again for giving me this opportunity, Professor Fass.
Thank you very much, Professor, for this very nice introduction. And first of all, it's a great honor for me to give this lecture to all of you. I'm very humbled for the opportunity, and good evening for all of you. Now, many of you probably may not know who is this guy. Maybe some of you do. But this gentleman is Sir James Black. And why do I bring his photo to you this evening? Well, Sir James Black is a very important person. He's not an academician. He worked for a drug company, for Glaxo. And he got actually a Nobel Prize for what I'm going to show you. He was actually the one that invented the first H2 blocker, cimetidine. And cimetidine was a huge breakthrough at the time because it revolutionized the treatment for peptic ulcer disease, which was a unique breakthrough during the early 70s. If you just read the history of how peptic ulcer disease was treated before the introduction of antisecretory medications. His contribution was so important that he received the Nobel Prize for it. The proton pump inhibitors were introduced in the early 90s, and they revolutionized the treatment of gastroesophageal reflux disease. While H2 blockers were available to us, and they were used in gastroesophageal reflux disease, there is no doubt that the introduction of proton pump inhibitors that were able to address severe gastroesophageal reflux disease, in particular erosive esophagitis, and specifically the various complications that are associated with gastroesophageal reflux disease like peptic stricture, esophageal ulcer, and others. What really made a difference in the treatment of these type of presentations of gastroesophageal reflux disease was the introduction of the proton pump inhibitors. And here is some examples where PPIs made a significant difference. Severe erosive esophagitis on the left and peptic stricture on the right. I always tell that when I was a fellow, I used to take care of patients in the peptic stricture clinic. But with the introduction of PPIs, that clinic had to be abolished because we don't see peptic stricture as much as we used to see in the old days. So here we are, and we have now a new class of drugs that is entering the global market. And this is the PCABs, the potassium-competitive acid blockers. And they obviously bring new opportunities of their own for acid-peptic disorders and specifically for patients with gastroesophageal reflux disease. I always like to show this slide because this is a historical slide. It's 24 years old. But what's interesting about this slide is that when you ask today, patients, what are the reported attributes that are extremely important to them when selecting stomach relief medication, we will always get the same response. The top three are fast-acting relief. They would like to have a medication that will relieve symptoms immediately. Second one, long-lasting, that the effect will be long-lasting. And the third one, that the medication will be safe. So that's been shown by many surveys in the last several decades. And so when we look at the different antisecretory medication that we currently have in the market, and now with the introduction of PCABs, then one understands that PCABs bring these three important attributes. This is a paper that we published a few years ago in JNM, Journal of Neurogastroenterology and Motility. And in this paper, we evaluated what are the areas of unmet need in the treatment of gastroesophageal reflux disease, knowing that we have proton pump inhibitors, which are very good medications for gastroesophageal reflux disease. As I already mentioned, they did revolutionize the treatment for gastroesophageal reflux disease, but we still have areas of unmet need. We put together about 13, and I can say that if I update this slide today or this table today, probably we'll have more. But here we have healing and symptom response in advanced erosive esophagitis remain an area of unmet need despite PPI treatment. Non-erosive reflux disease. Postprandial heartburn. So this is the heartburn that patients get as a result of a meal or spicy food or some trigger food or exercise, and they would like to have some type of treatment that address that specific heartburn. Nighttime heartburn. Maintenance treatment in erosive esophagitis, on-demand or intermittent therapy, refractory GERD, atypical manifestations of GERD, extraesophageal manifestations of GERD, dependency on food for efficacy, chronic PPI treatment with its potential adverse events, a growing number of publications in the last decade, Barrett's esophagus, or any intervention for Barrett's esophagus, post-bariatric surgery, gastroesophageal reflux disease, in particular, post-sleeve gastrectomy. And I would also add post-POEM, gastroesophageal reflux disease. So the list of areas of unmet needs is continue to grow. And as I said, brings some very important opportunities when it comes to PCABs. This is a recent review that I published in the New England Journal of Medicine. I wrote the clinical practice for gastroesophageal reflux disease. And in one of the tables, I also show you one of the issues that have been, that we've been exposed to it in the last decade or two, which is the growing number of publications reporting a variety of adverse events in patients that are taking PPIs long-term. And there's a long list of them, and it increases almost every week. One of the comments, for example, that I made in this table is that in patients with uncomplicated GERD who have response to short-term PPI therapy, there is an attempt that should be done to stop therapy. If symptoms recur, therapy should be reinitiated at the lowest dose that control the symptoms. So this is something relatively, I would say, new in the treatment of gastroesophageal reflux disease with PPIs that we had to introduce as a result of this growing number of potential complications of PPI treatment. Now let's look at the global PCABs market. Now, for those of you who are not familiar, PCABs were already were studied during the early 80s, long time ago. But they didn't end up in the market until 2005 when the first one was released in Korea, Vonoprazan. Now, what happened? Why there was such a long delay? Well, the first molecules of PCABs that were produced at the time were very hepatotoxic. And so they did not really meet the safety criteria for a drug to be released into the market. But it took a long time until these molecules were able to be modulated, and the cause, the part of the molecule that was associated with hepatotoxicity was modified, that we could have now the PCABs that can be used in the market. So the first one that was released into the Korean market, it was first in class, was Vonoprazan. It was introduced in 2005, and for some reason, it did not catch the attention of the practicing physicians. Potentially, maybe because its clinical performance was not that impressive. The first one really to catch our attention was Vonoprazan. Vonoprazan was released in 2015 into the Japanese market and was in fact the first PCAB that was very successful after its release, to the point that within 5 years, it took over the Japanese market, being the most commonly prescribed molecule or anti-reflux, antisecretory molecule as compared to the PPIs. Followed Vonoprazan, we had Tegoprazan, which is a PCAB that was released in Korea in 2018, and in 2021, Suppression was released in Korea as well. For those who do not know, we currently have, I think, about 10 different types of PCABs that are in different levels or different phases of drug trials. They're also trying to get into the market, the European market, Asian market, Latin American market. Many of them are new PCABs, and I think we are getting into a completely different time when it comes to antisecretory medications, where we're going to see more PCABs coming into the global market. Now, what's unique about PCABs? From a pharmacological point of view, the PCABs have several important characteristics. One, they have a very long plasma half-life. They're very stable in acid. They have a high accumulation rate in the parietal cell canaliculi, very slow dissociation rate, and they are primarily metabolized by CYP3A4 or 5. All of these pharmacological characteristics give them some very unique and powerful effect. They have a very rapid onset of action. They have a very potent acid control, and this potent acid control is durable over a 24-hour period. From a pharmacokinetic point of view, what is the difference between PPIs and PCABs? Now remember, PCABs are considered to be a new class of drugs. They are not second-generation PPIs or third-generation PPIs. It's a completely new class of drugs. So in relation to mode of action, PPIs they bind to the active form of the proton pump, where PCABs, they bind to active, but also to inactive forms of the proton pumps, which is an advantage. So PCABs can bind to dormant proton pumps that are in the cytoplasm of the parietal cell. PPIs are potassium-competitive, irreversible, with covalent binding to the proton pump, where PCABs are potassium-competitive, but reversible ionic binding to the proton pump. PPIs require transformation in acidic environment to become the active sulfonamide. So PPIs are prodrugs, where PCABs are not. They act directly. Onset of action of PPI is delayed. It requires repeated doses. Some suggest between 3 to 5 days until they reach maximum effect, where in the case of PCABs, they reach maximum effect immediately after the first dose. PPIs are acid-labile. PCABs are acid-stable. Half-life of PPIs is 1.5 to 2 hours, where in the case of PCABs, some of the PCABs, their half-life is up to 10 hours. In relation to dosing, PPIs, their activity depended on food intake. So you need to take PPIs 30 to 60 minutes before a meal. Where in the case of PCABs, their activity are independent of food, so you don't have to take it before a meal. The metabolism of PPI is primarily through CYP2CY9. This is the cytochrome P450 in the liver. We do know that CYP2CY9 has a polymorphism, which may affect the plasma levels and the efficacy of PPIs. For example, if people are fast metabolizer, that means they eliminate the drug relatively quickly, and we get less effect from it than, if, for example, if people are intermediate metabolizers or are slow metabolizers. In the case of PCABs, the metabolism is mainly by CYP3A4, and there is no polymorphism. So there is very low potential as a result for interpatient variability in plasma levels. In relation to drug-to-drug interaction, in the case of PPIs, there is a potential interaction, for example, with clopidogrel, because it's also metabolized by CYP2CY9, where in the case of PCABs, there is very low potential for drug-to-drug interaction because of metabolism by the CYP3A4. This is just that you will get an idea about the half-lives of PPIs as compared to PCABs. And you can see that PPIs, their half-life is between 1.5 to 2 hours, where in the case of PCABs, it's between 3.7 to 10.3 hours, where the longest half-life is of Vonoprazan, which can be up to 10 hours. And you can see that also Vonoprazan, its half-life is 6.1 to 7.7 hours. I think this is one of the most important slides that I will show you today, because if you understand that slide, you will understand the important value of PCABs and what they bring to the table as compared to PPIs. You can see that in relation to PCABs, their effect reach its maximum level immediately after the first dose. And if you keep taking it every day, then they basically are able to maintain this maximum effect. Well, in the case of PPIs, it may take up to 5 days to reach maximum effect on gastric acid inhibition. And that gives us a variety of clinical opportunities. And I will discuss some of them towards the end of my presentation. This is from a pharmacodynamic point of view. You can clearly see the effect of vonoprazan versus esomeprazole, vonoprazan 20 versus esomeprazole 20, and their effect on intragastric pH. Taken here by normal subjects for 7 days, you can see the effect of both of these drugs at day 1, and then after 7 days of daily medication. And you can see that vonoprazan, after day 1, reached already maintaining intragastric pH above 4, 71% of the time, and it went to about 86% at day 7. So very high already after the first dose. Well, in the case of esomeprazole, we can see 24% after day 1, and then it increased to 61% after day 7 or at day 7. So again, clearly showing the difference in pharmacodynamic capabilities of vonoprazan versus a PPI, in this case, esomeprazole. Now, how does that translate to an effect on effect at the clinical level? Here is the pivotal trial that was done in Japan, looking at the effect of vonoprazan on erosive esophagitis. Patients were randomized to lansoprazole 30 milligram or vonoprazan 20 milligram, and endoscopy was done at week 2, 4, and 8, and the study was concluded after 8 weeks. For grades A and B, you can see that there was no difference in healing between vonoprazan and lansoprazole, but clearly there was an important difference between vonoprazan and lansoprazole in relation to grade C and D. That difference was already noticed at week 2, where vonoprazan provided 22% therapeutic gain over lansoprazole after week 2. At the end of the study, vonoprazan provided 11% therapeutic gain for grade C and D erosive esophagitis, clearly pointing out that vonoprazan provides an important solution for one of the important areas of unmet need that I already pointed out, which is advanced grading of erosive esophagitis. Here you can see the same study looking at erosive esophagitis patients, all of them. Week 2, there was a difference with 9% therapeutic gain in relation to vonoprazan. And at the end of the study, it was a 3% therapeutic gain for vonoprazan as compared to lansoprazole. When you look again at the Los Angeles classification C and D, patients with what we call severe erosive esophagitis, week 2, 22% therapeutic gain for vonoprazan as compared to lansoprazole, and 11% at week 8. What about maintenance of healing of erosive esophagitis? So the patients that completed the acute part of the study, the 8 weeks, then those that achieved complete healing and symptom control were enrolled into a 6-month study where they were randomized to lansoprazole 15 milligram, vonoprazan 10, and vonoprazan 20 milligram. When you look at recurrence rate at 6 months, remember, this was also one of the areas of unmet need. Maintenance of healing of erosive esophagitis. Studies have shown that significant number of patients recur while they are on maintenance treatment, even if they have grade A and B. Some studies said up 20% and grade C and D up to 40%. Now, in the case of grade A and B, you can see the recurrence rate was higher in patients that received lansoprazole 15 milligram as compared to vonoprazan 10 milligram and vonoprazan 20 milligram. But it was most pronounced in grade C and D, where the recurrence rate in those receiving lansoprazole 15 milligram was 39%. And in those that received vonoprazan 10, it was 13% and 5% in those that received vonoprazan 20 milligram. Now, this is how it looks for all erosive esophagitis patients. Again, this is the same study. Recurrence rate was 17% after 6 months for those that received lansoprazole 15 milligram, 5% for those that received vonoprazan 10 milligram, and 2% for those that received vonoprazan 20 milligram. Again, clearly suggesting that vonoprazan provided a better maintenance of healing of erosive esophagitis with specific pronounced effect on the advanced grading of erosive esophagitis, again, addressing another important area of unmet need. The other thing that was found in this study, which is may reflect what we see in the pharmacodynamic data, is that when you look at symptom response, lansoprazole and vonoprazan, they already separate during the first week of treatment. When you look at daytime heartburn relief, you can see the separation between vonoprazan 20 and lansoprazole 30 milligram. And this is in particular pronounced when you look at nighttime heartburn relief, when you compare vonoprazan 20 to lansoprazole 30 milligram. Remember, when it comes to patients' expectations are that they will get a medication that will provide them fast relief. Now, this is the United States phase 3 randomized controlled trial, healing of erosive esophagitis. This was published last year. And vonoprazan is currently approved in the US for erosive esophagitis. This study is a large study, included 1,024 patients, and patients were randomized to vonoprazan 20 milligram or lansoprazole 30 milligram. In the acute healing, the 8-week study, the percent of patients that healed by week 8 was 93% of those that received vonoprazan versus 85% of those that received lansoprazole 30 milligram. Again, looking at grade C and D, the percent of grade C and D patients healed at week 2 was 70% of those that received vonoprazan versus 53% of those that received lansoprazole. This is 17% therapeutic gain. If you look at the percent of grade C and D patient healed by week 8, we can see it was 92% for those that received vonoprazan versus 72% of those that received lansoprazole. This is 20% therapeutic gain. And the percent of all patients healed at week 2 was 74% of those that received vonoprazan and 68% of those received lansoprazole. In this study, the design and the recruitment, the investigators made an effort to recruit 30% of the total patient with grade C and D, as you would expect in the US general population. When you look at the US phase 3 maintenance of erosive esophagitis, this is the 6 months follow-up. The percent of all patients maintained through week 24, which is the end of 6 months. In the case of vonoprazan 20, it was 81%. Vonoprazan 10, it was 79%. It was 72% for those that received lansoprazole. If you look specifically at grade C and D, it was 77% for vonoprazan 20, 75% for those that received 10 milligram, and 61% of those that received lansoprazole. In both studies, the acute study and the maintenance, there was no difference in symptom control among the different doses of vonoprazan and lansoprazole. This is a systematic review and network meta-analysis that I think it's in press as we speak in the American Journal of Gastroenterology, comparing the efficacy of the different PCABs versus PPIs for grade C and D erosive esophagitis. The authors found out that there were, in the initial treatment phase, which is the acute one, they had 9,267 participants in 13 randomized controlled trials. And the proportion of treatment failure, this is what they were looking for, was for PCABs was 6%, and for PPIs it was 21%. In relation to the maintenance treatment phase, they had 1,834 participants from 4 randomized controlled trials. And when they looked at the proportion of treatment failure, it was 21% for PCABs and 30% for PPIs. When they look at comparative efficacy of PCABs versus PPIs for these grade C and D erosive esophagitis, then vonoprazan was found to be the most efficacious medications, in this case the PCAB, followed by keverprazan and tegoprazan, 2 additional PCABs, and then we have a variety of PPIs. Now, how does vonoprazan perform in non-erosive reflux disease? And as I mentioned to you, non-erosive reflux disease is also considered to be an area of unmet need. Now, this is a phase 3 trial that was done in the United States. In this study, patients were initially randomized. All of them had non-erosive reflux disease to placebo, vonoprazan 10 milligram, and vonoprazan 20 milligram. If you look at the top figure on the right side, you can clearly see that PCABs were separating from placebo very quickly, immediately after day 1. And they maintained this separation throughout the 4 weeks of treatment. So when you look at 24-hour heartburn-free days, and this is a common clinical endpoint that is used in studies of non-erosive reflux disease, it was 27.7% for placebo as compared to about 44% for vonoprazan 10 and vonoprazan 20 milligram, and was able to be maintained throughout these 4 weeks of treatment. Subsequently, after completing the 4 weeks of treatment, patients who were on vonoprazan 10 milligrams stayed on it. Those on 20 milligrams stayed on that. But those that received placebo then were re-randomized to either vonoprazan 10 or vonoprazan 20. And then they were followed for an additional 20 weeks. If you look at the figure at the bottom on the right side, you can see the black dots represent those that were on placebo for the first 4 weeks. And then when they were randomized to vonoprazan 10 and 20 milligram, you can see now that their percentage of subjects with 24-hour heartburn-free days increased to the level of what you saw in those that were receiving vonoprazan 10 and 20 milligram from the beginning, clearly showing the advantage of vonoprazan 10 and 20 milligram over placebo. Again, we can see that the effect of vonoprazan was maintained throughout these 20 weeks. And if you look kind of overall, it in fact somewhat increases over this period of 20 weeks. And this is something that is very exciting for many of us because non-erosive reflux disease has been truly a challenging group of patients to treat. There are studies that looked at the value of vonoprazan in improving symptoms and healing in patients with refractory GERD, non-erosive reflux disease. These are all studies that were done. One of them here, I present here. All of them, in fact, showed the same thing, that in patients with PPI refractory GERD, vonoprazan provided more potent gastric acid suppression, more effective esophageal acid exposure control, more enhanced symptom improvement, and better esophagitis healing than PPI. So if you take a patient with GERD that failed treatment and you then randomize them to a PPI or vonoprazan, then the performance of vonoprazan in this specific patient population is much more efficacious. I want to talk to you a little bit about vonoprazan and non-continuous treatment for GERD. And I think that's one of the biggest opportunities that vonoprazan brings to the market today. Remember the pharmacodynamic information that I provided you with, and I told you that if you remember that slide, that will help you to understand the clinical opportunities that vonoprazan brings to the table. And one of them is the role of non-continuous treatment for gastroesophageal reflux disease. Now, we have several treatment strategies for gastroesophageal reflux disease. There is what we call the continuous use, which is commonly prescribed by practicing physician, where we give patients once or twice daily dosing until treatment is discontinued. Or we have what we call non-continuous treatment. One of them is called intermittent use, where patients will take short courses of 7 to 14 days following symptom onset, and the rule is that they cannot take more than once a day. There is also another option of intermittent use, which is the 9 daily dosing, where you take standard dose every other day, weekdays only, or weekends only. And by the way, that's been studied by several trials. Another non-continuous treatment is what we call the on-demand use, where patient initiate treatment at onset of symptoms and then decide to discontinue after symptom resolution. Again, the rule here, no more than standard dose per 24-hour is expected. Now, the two important non-continuous therapies for GERD that I mentioned, one is the intermittent and the other one is the on-demand. The intermittent is usually physician-driven. So what it's done with the patient is physician tell patients, whenever you have symptoms, initiate treatment for a week or for 2 weeks or over the weekends, because usually over the weekends, that's when you binge or you eat more. That's when you need to cover it. And then you stop and don't take more than once a day. On-demand therapies, on the other hand, is patient-driven. It's left to the patient to decide whenever they start treatment and for what duration. So it's for the duration they desire. Again, the rule here of the game is that they cannot take more than once a day. Now, what are the advantages of non-continuous or on-demand, of intermittent or on-demand therapy? Well, first of all, it's convenient for patients. Patient, for example, in the on-demand approach, they take whenever they feel they need the medication. Patients feel in control. It may reduce costs to patients, and it can reduce concerns about long-term complications of anti-reflux treatment. Now, for a medication to be an excellent on-demand therapy, it has to have the following four attributes. One, potent acid suppression. Second, rapid effect. Third, durability of effect. And fourth, flexibility of administration. You can take it whenever you need it. And when you look at all four medications, two that are currently used as on demand, like antacids and H2 blockers, PPIs, and potassium-competitive acid blockers, we can clearly see that PCABs, and specifically Vonoprazan, provide the most, the best attributes for on-demand therapy. Again, one of the areas of unmet need that I mentioned. Here are, this is a compilation in a table that we recently published in the Journal of Gastroenterology and Hepatology. We showed several studies looking at on-demand or intermittent dosing, most of them with Vonoprazan, and most of them showing the value of this approach in patients with gastroesophageal reflux disease. This is one study that was done in Japan where patients were studied for a period of 1 week. Patients were randomized to either daily lansoprazole or on-demand Vonoprazan. If they took daily lansoprazole, they had to take 7 pills, of course, because they took it for each day. But when they kept it as an option for those that received Vonoprazan, they took only 1.4 pills during that week of the study. At the end of the study, they found out that 77% of the patients that were taking on-demand Vonoprazan were content with this type of therapeutic approach, and they were willing to stay on it for the duration, where 23% wanted to be switched to a daily lansoprazole. This is a study that we published last year looking at the efficacy and safety of on-demand Vonoprazan versus placebo for non-erosive reflux disease. This was a randomized clinical trial. The trial design was that patients were screened for a period of 5 weeks, and then they went through a run-in period of 4 weeks where they received Vonoprazan 20 milligram daily. Those that reached complete symptom relief during the last week of treatment then were randomized to on-demand period of 6 weeks, Vonoprazan 10, Vonoprazan 20, Vonoprazan 40, or placebo. And they had also, after treatment was discontinued, they were followed for another week. Patients were using e-diary to record heartburn episodes. So if patients develop a heartburn episode, they had to report if they had a relief at 30 minutes, 1 hour, 1.5 hours, 2 hours, and 3 hours after study drug administration. They also reported about study medication use and if they needed to use rescue antacids. When you look at the the primary clinical endpoint, which was relieved heartburn episodes within 3 hours and no further heartburn reported during 24 hours after drug administration, then you can clearly see that the different Vonoprazan doses separated from placebo after the first hour post-drug administration. And it was maintained throughout the first 3 hours and subsequently for the first 24 hours after drug administration. 27.3% for those that received placebo as compared to 56 to 70% of those that received Vonoprazan 10 through Vonoprazan 40 milligram. When you looked only at relief of a valuable heartburn episode within the first 3 hours, which is the classic on-demand expectations. Again, the separation was very clear. After 1 hour after drug administration, it was maintained towards the end of these 3 hours post-drug administration with 41.9% for placebo, and for the PCAB different dosing, Vonoprazan here, between 65.7% to 79.6%. This study clearly shows the opportunity that we have in relation to Vonoprazan as a non-continuous treatment for gastroesophageal reflux disease. And we have a large patient population that are candidates for this type of therapeutic approach. This is the safety report at the end of the study. And in general, and I will not go into details, but there was no difference in relation to treatment emergent adverse events among the different doses of Vonoprazan as well as placebo. This is the serum gastrin measurements that were done throughout the study. There was somewhat an increase in the level of the gastrin, not a lot as compared to placebo at the end of the run-in period. And this was because during the run-in period, patients received Vonoprazan daily. And you can see that at the end of the 6 weeks, the levels was very low. In relation to treatment of Helicobacter pylori, no question that PCABs brings a very important opportunity for better eradication of the Helicobacter pylori drug, because better acid suppression appears to improve the effect of the antibiotics on the bacteria and better eradication rate. This is a study that was done in Japan, 7-day, and patients were randomized to either Vonoprazan or lansoprazole with 750 milligram amoxicillin twice a day, and clarithromycin 200 to 400 milligram twice a day. And comparison of all patients showed that eradication rate was much higher in Vonoprazan, significantly higher in the combination therapy that included Vonoprazan, 93% versus lansoprazole, 76%. But the effect was mostly pronounced in patients that demonstrated clarithromycin-resistant H. pylori, where it was 82% for Vonoprazan versus 40% for those that received lansoprazole combination therapy. This is the pivotal trial, the Helicobacter pylori eradication study that was done in the US. And by the way, Vonoprazan is FDA approved in the US for the eradication of H. pylori. Patients were randomized for Vonoprazan triple therapy, Vonoprazan dual therapy, or PPI triple therapy, and it was given over a period of 14 days. And post-treatment, the primary endpoint eradication rate was evaluated. The combination therapy included Vonoprazan 20 milligram BID plus amoxicillin 1 gram BID and clarithromycin 500 milligram BID. The dual therapy was Vonoprazan 20 milligram BID and amoxicillin 1 gram TID, and then you have the lansoprazole 20 milligram BID, amoxicillin 1 gram BID, and clarithromycin 500 milligram BID. Now, if you look at the patients' clarithromycin resistant strains, you can see that this was clearly statistically significant as compared to lansoprazole triple therapy. So both dual therapy and triple therapy were significantly higher than lansoprazole triple therapy, with something between 34 to 38% of therapeutic gain. When you look at all patients, then again, it was still statistically significant, both dual therapy and triple therapy versus lansoprazole triple therapy. And again, as I mentioned, vonoprazan brings an opportunity here of improving eradication in patients who are clarithromycin resistant, a growing problem in the US. This is when you look at treatment emergent adverse events, as the three arms comparing to each other, you can see that overall, no difference. Now, I'll show you towards the end several studies that looked at healing of gastric ulcer, duodenal ulcer. This is just a study that was done in Japan looking at vonoprazan versus lansoprazole in healing patients with gastric or duodenal ulcer. The study showed that there was no difference between the healing rates of vonoprazan and lansoprazole of both gastric ulcer. Treatment there was for 8 weeks, or duodenal ulcer, where the treatment there was for 6 weeks. This is actually a Kaplan-Meier estimates of cumulative incidence of the A at the top. It looks at ulcer recurrence, and at the bottom, bleeding in the stomach or duodenum in patients that receive low-dose aspirin. So looking at prevention of aspirin, low-dose aspirin-associated ulcer recurrence. And in this study, you can clearly see the superiority of vonoprazan 10 milligram and vonoprazan 20 milligram in both reducing ulcer recurrence as compared to lansoprazole, and in reducing GI bleed as compared to lansoprazole. This is another study that looked at ulcer recurrence in patients that require long-term NSAID therapy. And in this study, it showed, again, that those that received vonoprazan did better than lansoprazole, or did the same as lansoprazole in relation to ulcer recurrence or bleeding recurrence. So I'd like to finalize just telling you that when we look at adverse events of vonoprazan and its safety profile, in the clinical trials in Japan, there were more than 7,000 patients that have received the medication. And there was no dose-related increase in adverse events that was observed in these clinical trials. Since it's launched, more than 25 million people have received the medication, and probably by now more than that. And no important adverse events have been reported so far. The adverse events in clinical development that have been noticed, incidence of 0.1 to 5%, included diarrhea, constipation, nausea, rash, eosinophilia, and elevated liver enzymes. But when you look at hepatic events, for example, increase of ALT or AST more than 3 times of the upper limit of the normal, or bilirubin more than twice the upper limit of the normal, in vonoprazan, it was 1%, in lansoprazole 15 and 30 milligram, it was 0.8%. So very little difference between PCABs and PPIs. I really like to show that because it gives you really a story about what happened in Japan. Similar events have been noticed also in Korea. And it tells you what happened when vonoprazan was launched in Japan in 2015. At the time, Nexium, as you could see, esomeprazole, was the leader of the market. By 2020, vonoprazan became the leader of the antisecretory market, and it took over PPIs. In Korea, it happened within 3 years. PCABs have been now incorporated in several clinical guidelines of different countries, including the Korean, the Japanese, the Brazilian, the Chinese, and many others guidelines where now PCABs are part of the treatment guidelines for gastroesophageal reflux disease and Helicobacter pylori eradication. I'd like to finish here in a couple of slides looking at unique clinical opportunities that vonoprazan and PCABs bring to the table, which are beyond the traditional GERD indications. The first one is the PCAB test. Many of you remember the PPI test, where you can give a short course of high-dose PPI in order to make the diagnosis of gastroesophageal reflux disease. PCAB, because of its very impressive pharmacodynamic information, specifically vonoprazan, brings a very good opportunity from a PCAB as a PCAB test. We discussed the non-continuous treatment, on-demand and intermittent. We currently don't have in the US any approval for on-demand or intermittent or any type of non-continuous treatment. Potentially, vonoprazan can bring the first time that this will be approved. Specifically addressing nighttime GERD because of a very long half-life. Most patients with GERD have both daytime and nighttime GERD, and that's why we need to give them the medication in the morning, the PPI. But if you have a very long half-life, these type of the PCABs could bring an important resolution for nighttime GERD. Extraesophageal manifestations of GERD. This is a very important area of unmet need, and it brings new opportunities. Refractory erosive esophagitis. Reflux hypersensitivity, which is not considered to be a gastroesophageal reflux disease. It is considered to be a functional esophageal disorder, but it has been shown to respond to PPI treatment, and potentially PCAB may provide a better response than PPI. Post-POEM or post-sleeve gastrectomy GERD, and in patients that require double-dose PPI to control their symptoms, how about stepping them down to once daily PCAB? So I'd like to conclude here that PCABs are a new class of drugs with unique PK and PD characteristics that are different from PPIs. PCABs provide solutions for many areas of unmet need in acid-peptic disorders. Vonoprazan provides a profound, rapid, and sustained acid suppression. Vonoprazan is effective in healing and maintenance of erosive esophagitis, symptom control in non-erosive reflux disease, and symptom improvement in refractory GERD. Vonoprazan is effective as an on-demand therapy in episodic GERD, and triple and dual therapy with vonoprazan result in higher eradication rates of H. pylori than with a PPI. Thank you very much for this opportunity.
Thank you very much, Professor Fast, for that excellent. I can see Dr. Mohan Prasad applauding to the session. I'm sure this was worthy of applause. Thank you so much. Comprehensive, concise, lucid, all of it. This was. I will request Dr. BGM Sir now to take us forward with the panel discussion. Sir.
Wow, that was amazing and a crystal clear deliberation on the new PCAB vonoprazan that has entered into India. And you shared all your wisdom of years of research on this molecule also. So now we have an elite panel here. We have Professor Shobhana Bhatia and Professor Sunil Dadich, Professor Sanjay Banerjee, and Professor Ravindra. They're from, East, West, and South. So they've all been using PPIs all along. Now there is a new molecule which has come into our nation. So I want a 30-second response from each one of them, starting with Shobhana ji. So would you switch from PPI to PCAB in your clinical practice, after having heard about all the positive features of PCAB? So Shobhana ji.
So can you hear me, Dr. Mohan Prasad?
Very well. Yes, ma'am.
So the first thing I have to say is every new molecule always looks very good as soon as it comes. Of course, this molecule's been around for more than 10 years and we've been reading about it a lot. Given that there are some patients who do not heal with PPIs or have not much response with anti-H. pylori regimes, I would, if I had to switch, I would switch in patients who are not responding to PPI. My first drug of choice in patients with AB esophagitis or NERD or patients with just heartburn would still remain a PPI. But I would go to Vonoprazan only in, say, grade CD esophagitis or where the patient is not responding to PPI. And the second is in H. pylori treatment. I think I might even supersede the PPIs and replace the treatment with Vonoprazan in indicated cases of anti-H. pylori treatment.
Yeah, well summarized, ma'am. So you would stick on to PPIs for the majority of the situations. You will switch to Vonoprazan in a few indications, as you mentioned. So let us now hear from Professor Sunil Dadich. So what would you do, sir?
Yes, sir. I'll agree with Dr. Sobna Bhatia regarding the indications. I would add on few more indications from my side. I will also use it in patient with peptic stricture, in patient who have Barrett's esophagus, and patient who have bleeding peptic ulcers or gastric ulcers. So those who have a active large ulcer in the stomach or duodenum or a artificially induced like a following ESD or POEM or something, some resection. So I will prefer this compound over the existing PPI, apart from its use in grade C and D erosive form of esophagitis. And also I will prefer this drug as an on-demand therapy and as a anti-H. pylori eradication therapy. Yes.
Yeah, and before I pass the question to Professor Sanjay and Ravindra, I have a question to Professor Fas. You know, like a patient comes and gets admitted with an upper GI bleed, peptic ulcer bleed, and the conventional methodology to treat is pantoprazole infusion, 200 milligrams, 40 milligrams stat, and then 200 milligrams in 24 hours. Do you think that this can be replaced by taking a pill of, Vonoprazan 20 milligram? Or still should we go with parenteral route of administration, at least for the first 48 to 72 hours? Professor Fas?
Yeah, so there is data to show that you can take PCABs from the beginning. The only limitation, of course, that in some patients you may need to give them IV infusion for other reasons because you cannot give them an oral treatment. But there is already some early studies showing that that you can take a PCAB already up front.
Even when there is blood in the stomach or after a ceased bleed?
So at least there is a study that looked at the value of it in patients with a GI bleed and showing that it does work even if you take it up front, as I said, regardless if they have blood in the stomach or not. Now, again, we have very few studies that looking into it. In the US, none of them was done. So I have to rely on some studies that were done in other countries. Personally, I think we need, from my point of view, is we need more data about that before we initiate oral upfront instead of IV.
Thank you, sir. So over to Professor Sanjay Banerjee. Do you have any more indications that where you would jump from PPI to PCAB?
Sir, I would echo whatever said by my previous panelists, Sobna ma'am and Dr. Dadhij. My choices would be erosive esophagitis not responding to PPI, maybe severe grades of C or D esophagitis, where I would prefer a PCAB over PPI, and non-erosive groups who maybe benefited from the on-demand therapy because PCABs open a scope for an on-demand therapy, which in most of the cases for PPI is a continuous therapy. Now, there is a group of people who, because of mostly nocturnal acid breakthrough, consume twice daily PPI. I am not going into merits or demerits of it because there could be objection whether adding H2RA, etc. But there are still some people who are dependent on twice daily PPI. And in this aspect, I would rather switch over to a single daily PCABs in this group of patients. Regarding NSAIDs-induced and ulcer prevention and H. pylori, I think we need more data in Indian context to come up to give a clear picture.
Now we'll move to south. We have gone from northwest to east to south. Yeah. How about Ravindra, sir?
I think basically I would like to switch in H. pylori. Definitely there is a great data. H. pylori, I think Vonoprazan I'm going to use. Grade C, grade D esophagitis, because even though it is a small percentage, it may be 2%, even in everybody's practice, it is 2% only grade C, grade D. I think that's one indication we are going to switch. I think people who are non-erosive reflux, not so well controlled on PPIs, probably that is one which we are going to switch. I think the recommendations at this moment, we should stick to grade C, grade D, H. pylori, and then PPI failure, non-erosive reflux. I think this is one indication I would like to immediately switch, because there is a definite benefit in these three scenarios. Rest of the things, I think scientific data has to emerge, especially GI bleed, all these things, I think we'll have to have a scientific data yet to come.
And rightly said. And in fact, Dr. Sanjay touched upon the nocturnal acid breakthrough. And if you see the sucra values, interesting. Tegoprazan, 91.8%. Vonoprazan is 91%. When compared to the tenetoprazole and elaprazole are much short, like 76.6%. And if you add a H2 blocker, it's only 61%, which shows a true superiority of the PCABs over the PPIs. Even the so-called tenetoprazole, like we used to have, when there was a choice, we used to choose elaprazole if there is a nocturnal acid breakthrough. But even they have only about 71%, whereas this PCABs give a better suppression of acid in the night. So NAB is, as Professor Sanjay pointed out, it's a beautiful drug for NAB. So I have a question to Professor Fass. So, like after stopping the treatment, the positive beneficial effect goes even beyond, even after cessation of therapy. So how does that happen? Is it because of the healed esophagitis, it takes time for again recurring, or is there something else happening?
So if you can further expand on your question.
No. Like, for example, we treat erosive esophagitis for 6 months with the PCAB, like Vonoprazan, and then you stop it. But patients don't relapse for quite some time, off therapy relapse. So they don't relapse for a long time. So why does that happen? How does that happen?
I'm not sure. So the experience is, and I didn't show the slide, but if you take patients with erosive esophagitis and you stop treatment, then within 6 months, close to 90% of them will relapse. So it is unlikely that they will not relapse. And they tend to relapse to the grading of erosive esophagitis that they have at baseline. So it may take time for some of these patients to return back. Studies have shown that it takes between 2 to 4 weeks for an erosive esophagitis to reach its original extension. So if somebody was healed with a PPI or a PCAB and you stop it and then you follow the patient, between 2 to 4 weeks, they will reach back to their the erosive esophagitis that they used to have. From a clinical point of view, because you're limited in how often you scope the patient, it's been shown that if you follow them for a period of 6 months, up to 90% will relapse.
Yeah, that means, it's well said, and all erosive esophagitis patients have to continue indefinitely the treatment. And again, my question is, if you put them on demand, PCAB use, the acid suppression may not be profound all through the week. And will that affect the recurrence of erosive esophagitis? In this population, would you give a daily dosing or would you still allow a symptom-based on-demand therapy?
Okay. So I don't think that non-continuous treatment has a role in advanced grading of erosive esophagitis. I think in this patient population, they will need to take treatment, even in the case of PCABs on a daily basis. So this is not really the group of patients I would like to see non-continuous treatment. In patients with grade C and D erosive esophagitis, these are the patients also that we're concerned about developing peptic stricture over time, or esophageal ulcer that can be associated with esophageal bleed. So I would not consider the on-demand or intermittent approach in this patient population. Where would I position it? I would position it in patients with non-erosive reflux disease, where we do know that these patients tend not to progress over time. Studies have shown that patients with non-erosive reflux disease tend to stay as non-erosive reflux disease. So why not considering non-continuous treatment in this patient population? We are not concerned about progression. In many of these patients, symptoms are episodic, and so they would like to take medication whenever they need it. So they would be a very good group of patients that I would consider non-continuous treatment in this patient population. I would not even consider non-continuous treatment in patients with non-erosive reflux disease that have daily symptoms, or they have a lot of symptoms, because obviously they need more than intermittent therapy or on demand. They will need treatment on a daily basis.
And
in relation to,
sorry, yeah, please.
Yeah, in relation to erosive esophagitis, definitely not C and D. Grade A is not considered to be inconclusive for GERD. I wouldn't mind to consider these patients as well as potential for a non-continuous treatment. In relation to grade B, it's very interesting because grade B has such a huge range. Remember, all you need is more than 5 millimeter, one erosion to be called grade B. But at the same time, you could have 10 centimeter erosion, which is grade B. But I would say in those that have very small erosions that I consider as grade B, potentially. Grade B, I would look into it separately to see if they might be also considered for non-continuous treatment, but not all grade B. So this is kind of my overall gestalt about when to use non-continuous treatment.
And in patients who are on aspirin or non-steroidal drugs for rheumatoid arthritis and so on, like, do you continuously put them on a 10 milligram dose nonstop, lifelong, co-prescribed?
Yeah. If the patients, they have risk factors for ulcer disease and bleed, if they have history of ulcer or bleed, I would put it on a daily basis. I would not consider. I mean, for me, the non-continuous treatment at this point is limited to the patient population I just discussed. But I mean, it's open for discussion in general about the value in other areas, and see if that works there as well.
Professor,
now, what I would do now, I will request the 4 experts to raise any queries to Professor Fass, and then we'll move on to the questions in the chat box. A lot of questions have flown in. So first to Professor Ravindra, you can come
Professor
up.
Fass, see, Vonoprazan has got a very long half-life. Why are we using double dose of Vonoprazan in H. pylori? Is there any studies where they have looked into single dose Vonoprazan with the 2 antibiotics? Because compared to all of them, it has got a very good half-life. Why is this not been done? Or is there any studies which have been looked into?
So I'm not aware of that. I think your question is a very good question, and it makes sense. But obviously, the studies were done with double dose in the hope of getting to maximize the acid suppression.
I think that's what they said, that profound acid suppression is of paramount importance for eradication of H. pylori. So use the maximum dose, double dose, and go on. That is the concept. So
I have a question.
please, Sanjay ji.
So, Dr. Fas, is there any role of this group of drugs in functional dyspepsia? Do you have any evidence or any literature to support?
Yeah. So there are, again, these are small trials that were done in different countries where they used functional dyspepsia. Sometimes it's not really falling into the category of how Rome defined functional dyspepsia. Again, overall, PCABs has the same value, it appears, as PPIs in treating these patients with functional dyspepsia. Obviously, the value there is limited in functional dyspepsia because we do know that in a significant subset of these patients, it's not H. pylori that is causing their symptom, and it's not reflux or reflux related or others, and it may be other mechanisms like hyperalgesia and others that may lead symptoms in this patient population. But the studies do show that PCABs work as well as PPIs in this patient population.
Okay, so can I ask a question, Dr. Monteson? Yes. So, Dr. Fast, just a quick one. That, when we were using the PPIs in all the studies with grade C and D esophagitis, there is a 30% discrepancy between the healing of the esophagitis and the relief of heartburn. So what's happening with Vonoprazan here?
It's an excellent point. That's true, by the way, what you just said. That's excellent. So many of us don't pay attention to it, but it's true. The studies have shown that there is a discrepancy between healing of erosive esophagitis and symptom resolution. All PPI studies have shown that. And we see that also in the PCAB studies. So we do have patients with erosive esophagitis healing that continue to have symptoms. And the question is, what drives those symptoms in those that do demonstrate complete healing? This also explains why when you look at the comparative trials between PPI and PCABs in patients with erosive esophagitis, there was no difference in symptom control between the two groups, while there was an impressive difference in relation to healing of erosive esophagitis. So we still see the same effect in PCABs, which probably demonstrate that while healing is a clinical endpoint that we can achieve in a greater percentage of patients with erosive esophagitis when it comes to symptom resolution, we still see that there is important difference, which tells us that when it comes to symptoms, there are additional players that lead to symptoms in our patients.
Right.
Can I ask you one?
Yeah, please.
When does the acid suppressive effect of vonoprazan reaches a plateau? Like if you increase the dose, will it further suppress the acid secretion? Or with one dose, it reaches to a maximum benefit? Repeating the dose or increasing the dose, will it have additional benefit in acid suppression or not?
Yes, it does. So when it comes to, when you give one dose of PCAB, you reach, and especially it's important, for example, in GERD, to get it above 4, pH 4 in the stomach for a longer period of time, and that's what you get. When you give it as a double dose, you get it above 6, pH above 6 for a longer period of time. So double dose does give you an additional effect in maintaining intragastric pH above 6 over a longer period of time.
So I think we will move on to questions in the chat box. What I'm going to do, I'm going to ask the Indian experts all these questions. And Professor Fast can always unmute and pass his comment also, additionally to strengthen the thoughts.
Yes.
That's my Alexa reminding me for dinner. I'm really sorry about it. Okay, so the first question comes from A.K. Gupta. For how many days Volstar can be taken continuously? So any of the Indian experts can answer? How long can they take?
I
It
think grade
depends
C,
upon
grade C, grade D, I think it will be permanent. I think that's the answer at the moment. And for all other things, it will be 8 weeks and later on demand.
Professor Fast, in the Japanese arena, which the drug has been there for 9 years, have there been subjects taking the drug for 9 years, non-stop?
So they do have subjects that have been on the drug for the duration. I'm not sure if they have it for 9 years, but they do have a registry where they follow patients that have been taking the drug on a daily basis for a long period of time.
And the next question comes from Dr. Atul Kumar Pal from Nagpur. How is it better than other proton pump inhibitors? I think I would answer this question. I think beautifully shown by Professor Fast. This was all put up before Professor Fast's speech. And now I'm sure Atul would have understood. The efficacy is much better when compared to proton pump inhibitors, be it ERD or be it NERD, whatever. So next question is from Dr. Rahul Gupta from Kolkata. What, if any, are absolute contraindications of vonoprazan? So what is the dose adjustment required for CKD patients? So contraindication, any of the Indian experts? Is there an absolute contraindication?
Not that I'm aware of, but I have not used the drug, so I will not be able to.
I think except for an allergic reaction or hypersensitivity to any of the ingredients, that's what the label says. So anything, Professor Fast, any absolute contraindication to this molecule?
maybe
Not in patient because it's not metabolized by the kidney, so there's no concern about renal insufficiency.
but in
yeah.
liver disease, in acute liver failure, or probably a advanced stage of cirrhosis, probably you will avoid using this drug.
Yes.
I think there is a point that vonoprazan is metabolized by another CYP system, CYP2B6 and CYP3A4 by 5. And clarithromycin also gets metabolized by this.
Exactly. 3A4 is where clarithromycin also undergoes. But
So
still a combination of clarithromycin and vonoprazan in H. pylori eradication regimen has not shown any sort of problem of clarithromycin dose, alteration. Is there any scientific proof that the clarithro dose gets altered if you combine it?
I don't think there's any data on this so far.
Again, not only CYP3A4, there are multiple. See, one is the oxidative metabolism and non-oxidative metabolism. So a portion of the drug undergoes non-oxidative metabolism. Only a portion of drug undergoes oxidative metabolism through the cytochrome P450 system. Again, through multiple cytochrome P450 enzymes. It's not one particular enzyme. Even 2C19 also it undergoes, but then to a small level. So I don't think, and the dosage adjustment they've said is, if the like EGFR is below 30, use a 10 milligram dose, and if it is up to 60, you can use a 20 milligram dose. That's what the literature says. And what is the maximum tolerated dose of vonoprazan? Again, Professor Fast answered in his question. In his deliberation, you can use even 40 milligram dose. But are there any studies beyond 40 milligrams?
In the States, we have only 10 and 20 milligram approved, and it is my understanding that this is the doses that are approved. 40 milligram was studied, but I'm not sure it is approved anywhere. The only use of the 20 milligram twice a day is for the H. pylori eradication. It's the only time, but no other applications for more than 10 and 20 milligram.
I think, Dr. Fast, in your study in APT, you have used 40 milligram, 10, 20, and 40.
It's correct. We did. We did not see. I mean, if we're going to get an approval for non-continuous treatment, the on-demand, it will be probably for the either 10 or 20 milligram. It's not going to be for the 40. You know, when you do a study, you can use the 40 milligram, but right now, I don't see approval for 40 milligram.
I have a question from Balasore, Dr. D.K. Das Mohapatra. And the question is dosage of Vonoprazan for eradication of H. pylori and how long? It has been very clearly mentioned that it is double dose of Vonoprazan 20 milligram twice a day, so long as you use the antibiotics like 14 days if you're using a triple. How long Vonoprazan can be given for GERD at a dose of 20 milligram per day? Again, we discussed this, indefinitely. And Ramesh Bhargav from Bhopal asked, can you add with other PPI? Why do you need to? Any of the Indian experts?
I don't think any need.
I don't.
Yeah, it's superfluous to do that. And Sharda Prahlad from Nashik has asked, which is the best antacid for elderly people? And I don't think when it comes to a question of Vonoprazan, probably that will act like an antacid. You don't require an antacid or sucralfate because one, the safety features are good and it's so quick to act. So, and Aparna from Mumbai, Vonoprazan benefit over existing therapy, especially in patients with NAB. Again, we have discussed on this subject. And Shailesh from Mumbai, compared to PPIs, how do we compare the CYP2C19 capacity of Vonoprazan with PPIs? Can we co-prescribe Vonoprazan along with clopidogrel in post-PCA patient? Absolutely. You can co-prescribe because what happens with clopidogrel, it's a prodrug that needs to be converted into an active moiety by cytochrome P450 CYP2C19. And so if PPIs competitively, go and bind with the CYP2C19, overwhelming the clopidogrel, so clopidogrel might get passed off as a prodrug. That is a fear. I mean, in theory, but in real life situation, it does not happen. So nobody has proven. But Vonoprazan does not go through cytochrome P2C19 pathway in a big way. It uses it in a very small extent. So you can co-prescribe very safely Vonoprazan with clopidogrel. In fact, probably I would do that. In polypharmacy, probably Vonoprazan will be a better drug than even a PPI. Sanjeev Katak. So again, how many days can we use? Is it hepatotoxic in the long-term use? I'm asking the Indian panelists.
So there's really no data. The first drug that was Revaprazan was taken off because of its hepatotoxicity. But the subsequent one, I think Dr. Ronnie showed in his slides that the incidence of hepatic side effects is less than 1%. He showed it in one of his slides.
Yeah, 0.8 versus 1%.
1 to 2%.
Yes.
And again, to our Indian panelists, is there any rebound effect if you stop the drug? Like PPIs, once you stop, there is a rebound of acid. Do you think the same thing will happen here?
I think in theoretically it should happen. It should happen.
That's exactly what Professor Fast was also telling. Erosive esophagitis patients come back within 4 to 6 weeks of cessation of therapy, indicating there is an acid rebound and probably more reflux. Okay, so and Girish Taori from Indore, as many PPIs come in combination with prokinetic agents, that is in India. So do we need to give prokinetics along with Vonoprazan to our Indian panelists?
No, I think it should be strictly banned, in my opinion, because people are using three times PPI with prokinetics. I think government and pharmaceutical companies, they should not use this combination at all, because patients, if they feel better and then they take 2 times, 3 times, and then people are taking levosulpiride 75 milligram, domperidone 90 milligram, and then etopride, it's a huge quantity. I think it should be banned.
It's absolutely misused. That is very sad.
I
So,
agree with Ravindra. Yes.
and Sayantan Rudrapal from Agartala, is it safe in pregnancy and pediatric patients? We have no data. So we would wait for data. Anjan Ghosh, best time to take So is it in the morning, night?
Anytime.
Anytime. Yeah, that's the right answer. And Katkar from Mumbai, on-demand use of vonoprazan seems promising. Can you suggest a suitable patient profile for on-demand use? We discussed just now. Professor Fast beautifully put it, like probably non-erosive reflux disease, uh, who are asymptomatic, not the symptomatic guys, can have an on-demand. Okay, Chittaranjan Panda from Cuttack, would a single evening dose for vonoprazan be appropriate for GERD patients having nocturnal heartburn symptoms? I believe so. So what about others, panelists? So would you see PPIs, we say always half an hour before breakfast because we need all the proton pumps to be awake and not asleep. And here, like there is no, dependency on the meal. And so whether you take it in the morning or night, probably, you can take it at night. That's
I
what I
think it is a big advantage, especially for whenever we were explaining with PPA with for H. pylori therapy, it was a big problem to explain this one to take before and this one after. With this, we can say all after food. I think that's a big advantage for us.
Correct.
And the last two questions.
Just a quick response to that patient who had, they talked about nocturnal symptoms. Many patients who have nocturnal symptoms also have a lot of regurgitation. So in patients with regurgitation, the symptom profile may be slightly different. In that the heartburn will be suppressed, but the volume reflux might still remain. So these patients will need to be counseled in a different manner altogether.
I think these patients should undergo impedance pH-metry and you demonstrate nocturnal acid surge. And sometimes we have had patients for in one patient, the acid remained in the esophagus for 190 minutes at night. And this guy had severe reflux, erosive esophagitis, grade D. And so indicating that these are guys who will really get benefited with vonoprazan. But as Shobhraji pointed out, volume reflux is yet another feature that we have to consider. If we see volume reflux, prokinetics really have to be used. They really have great help. Apart from lifestyle modification and, like raising the head end of the bed and going to bed 2 hours after a meal and avoiding heavy food or spicy, fatty, oily, fried food at night. So, as acid is suppressed, effect on B12 and vitamin D3, any data? So, I'm sure the acid suppression, whatever be the cause, be it PPI or be it, the PCABs, probably will suppress the B12 absorption. So,
I
any
think
comments on this?
I think Professor Fas, what is your this thing on this? Because B12, magnesium, iron, compared to head with PPI, with PCABs, and also lot of nodules, the hyperplastic polyps which we develop.
So there are some case reports that already reported about magnesium, hypomagnesemia as a result of PCABs, but it's still limited to case reports. Remember, the market where we have it the longest time is the Japanese market, where it's been going on for 9 years. So we still need to have some more information to see in relation to chronic treatment, its potential adverse events. There are some reports about C. difficile, limited reports of C. difficile and some enteric infections. And I think I've seen also one recent report about effect on kidney function, but so far it's been very limited.
And Professor Ross, Professor Fast, I have a question for you. I'm sorry. Yeah, actually, the vitamin D absorption can be defective, and calcium absorption can also be defective if with profound acid suppression, with PPIs or with PCABs. But the osteoclasts have proton pumps. And so once they get inhibited, the remodeling of the bone doesn't happen properly. And so the fractures, pathologic fractures could happen in theory. So do you think that same effect will apply for PCABs also?
So I have a different view on this. While you're right about the proton pumps that are also available, that are also located in other areas, not only in the parietal cell. And some of bone remodeling is done in an acidic environment. But when you look at prospective trials, there are several of them at effect of PPIs, chronic PPI treatment. They have not noticed any significant changes in relation to osteoporosis or other changes. There are several studies that have reported that. For me, I'm not that worried about it. I mean, the fact is that and I have to speak about the US market, and if you look at the AGA recommendations and ACG recommendation, they do not recommend to do DEXA scan in patients that are taking PPIs on a regular basis in order to evaluate for the evolution of osteoporosis, because we do not think that eventually it leads to a significant osteoporosis. The same thing when it comes to B12 or other vitamins. I'm not sure how it's done in India, but there are no recommendations today by the AGA or the ACG to perform routine vitamin assessment or mineral assessment, because there were some minerals that were suggested to be affected by chronic PPI treatment, because we could not see those changes. The only thing that we were able to see in the prospective long-term trials of PPI treatment is some enteric infections that were a little bit higher in those that received PPI as compared to those who did not. So I don't see a reason at this point to perform any of these tests on a routinely basis in patients that receive PCABs, unless, and I always say unless, we get different information in the future.
I think that makes life easy for us, because all these tests are expensive for an Indian patient, and you cannot keep on repeating them on a routine basis. So that's good news. And last question to Professor Fass, and then we'll have quick comments from our Indian faculty, and then finally Professor Fass for his words, and then I hand over to Ajanta. So any data on Zollinger-Ellison syndrome and the use of PCABs to Professor Fass?
I haven't seen any. I was looking for it. I think it's a great opportunity, no question. Zollinger-Ellison, you have to remember that Zollinger-Ellison is extremely rare. I have to say that I haven't seen even one during my career. I read a lot about them. And I do have a clinic that focuses on acid-peptic disorders. So these are very difficult studies to do because there aren't many of them. In the past, in the US, they were done primarily by the NIH, because they used to have a guy by the name of Robert Jensen who used to collect those patients, and they were able to do studies in this patient population. But no question, Zollinger-Ellison is one of the opportunities when it comes to PCABs.
Well, over to the Indian faculty for their quick comments, and then finally to Professor Fass, and then I hand over.
No, I think it's PCABs. I think GRD, CD we should use. H2 blockers we should use. But please don't use PPI with prokinetics. The combination, that is one we should avoid. Second thing is these PCABs should not be used with antibiotics, which is a very, very bad thing in India. People, many of them, they do with antibiotics. Using PCABs or PPI is a strict no. I think these are the 4 important messages we should give to the audience.
Thank you.
Dr. Sunil?
For de-escalation of PPI, those people who are long-term so-called addict to PPI, double dose, maybe a single dose, I think these people can be de-escalated by using a lower dose of PCABs initially, and then subsequently they can be taken off the PCABs and other acid-suppressing drugs.
Good point, sir. Yes. Shobna ji?
So I'll give a philosophical perspective. Many years ago when ranitidine first came into the market, I think Zinatac was labeled as one of the highest selling drugs in the world.
Exactly.
And then Dr. Fass showed us some data on how Esomeprazole was the maximum selling in Japan before Vonoprazan came, and now Vonoprazan touched that. So every subsequent generation of acid suppression is overtaking the other. I don't know what's going to happen in the future. So
this is like Tesla.
Tell us about the future.
This is like Tesla sales overtaking Toyota, and then
Yes.
now it is stabilized. We don't know what's going to happen now.
Yes.
So over to Dr. Sanjay for quick comments.
I think erosive esophagitis, this Vonoprazan or PCABs are going to replace PPIs. But the cases of non-erosive esophagitis and cases of functional dyspepsia far outnumber that of erosive esophagitis. So if you can address that thing, the superiority or inferiority of PCABs in PPI, I think a large proportion of our patients will be benefited. And one thing is still a mystery for me is that the efficacy of vonoprazan-based triple therapy has been established by several meta-analyses as early as in 2017 and 18. But surprisingly, neither the American College of Gastroenterology nor the latest Maastricht consensus in 2022 has any mention about vonoprazan.
I think the answer has to come from Professor Pass. Why is this? That the guidelines haven't adopted.
Still with PPI.
Some of the, American guidelines.
And Maastricht consensus of 2022.
The reason for that is that both guidelines came out before PCABs were approved in the US market. So, because you made the comments, I bet that this would be an opportunity for new guidelines in the US.
Yes.
Thank you.
And under your leadership, sir. So thank you so much. So I just enjoyed and learned a lot, like all of you. And I think there were, I think a few thousand people had registered for today's webinar. So it is a tremendous success. And thanks to Ajanta Pharma for bringing a world celebrity to be with us in this evening symposium in India. So thank you so much. I hand over to Ajanta Pharma to take over Dr. Deepak.
Thank you very much, sir. This promised to be a scientific extravaganza, and I'm sure it over-delivered. Vonoprazan, the game changer in the management of APD, is poised to be a game changer based on the world celebrity, as you mentioned, as well as Indian celebrities with huge world exposure. I will now hand over to Mr. Amir Kumar Pati, the cluster head, for the formal vote of thanks. Thank you very much to all the esteemed panel as well as invited speaker. Over to Amir Kumar Pati, please.
Thank you, Dr. Deepak. Thanks a lot. As we conclude today's enlightening it is my privilege and our heartfelt gratitude on behalf of Ajanta Pharma to everyone who contributed to its success. First and foremost, we extend our heartfelt gratitude to Professor Dr. Vonoprazan, our esteemed speaker today. Sir, your presentation on Vonoprazan, the game changer in the management of APD, has been both enlightening and inspiring. Your deep knowledge, coupled with your ability to communicate complex ideas in an accessible manner, has significantly enriched our understanding and providing us with a new perspective on Vonoprazan in the management of APD. We truly appreciate your dedication, sir, and the time you took out of your busy schedule to share your expertise with us. We also extend sincere thanks and appreciation to our moderator, Professor Dr. V.Z. Mohan Prasad, sir. Your skillful guidance ensured that our discussion were both engaging and informative. Equally, we like to express our sincere thanks and appreciation to our esteemed panelist, Professor Dr. Sovna Bhatia, Professor Dr. Sunil Dadij, Dr. Sanjay Banerjee, Dr. Ravindra. We are incredibly grateful for your contributions, sirs. Your diverse perspective and in-depth discussion has provided us with a comprehensive understanding of the topic covered. Thank you for your dedication and for the time taken to share your expertise with us. We also thank to our doctor attendees who joined us from various parts of country, taking their time out from the schedule. Your presence, attention, engagement were crucial in making this event a resounding success. Your questions and interaction add depth to the discussion, making this a truly collaborative and enriching experience. Thanks to Team Ajanta and our event partners for their relentless effort in putting this event together and making it a mega success. Wishing you all a pleasant evening ahead. And Dr. First, a good day to you. Thank you, Dr. Deepak. Thanks, all the panelists.
Thank you. Thank you very much, sir.
Thank you, everyone.
Thank you.
Thanks.
Thanks,
Bye-bye. And
Thank
good night and good day to you, sir. Bye.
Have a nice day.
Thank you. Same to you.
Thank you so much, ma'am. Thank you, sir.
Thank you.